with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Em Ly à? Thế sau
Good afternoon, everyone. It's time to start. Okay, this is a debate session, special focus 3, patient with stable chest pain debate session. Welcome to everybody for coming this session. I'm Dr. Hwan Seok-yong from Korea University, Seoul, Korea. I'd like to first present a lecturer and my co-chair, Professor Lee Ngok Ha. He is head of a nuclear medicine department, military hospital 108 and Critical Institute of Clinical Medical and Pharmaceutical Science 108. And his specialty is nuclear medicine physician. He is associate professor in radiology and nuclear medicine, Clinical Institute of Clinical Medical and Pharmaceutical Science, and associate professor in oncology faculty in Military Medical University. He published 7 articles. The topic of Professor Ha is more evidence. Spec is the best. Professor Ha, please give us a lecture.
Good morning. I am Dr. Lee Ngok Ha, head of nuclear medicine in Hospital 108 in Hanoi. Thank you, organizers, for kindly inviting me to participate in this conference. I think this is a very, very special meeting in the COVID-19 pandemic. Today, the topic I would like to share with you is a Spec myocardial perfusion imaging in stable coronary artery disease. So as you know, the non-invasive method for cardiac imaging have developed rapidly during the last 10 years. It is both obviously in the field of suspected or known CAD, and the technique as employed for the evaluation of diagnosis prognosis and risk stratification. This slide shows in coronary artery disease, myocardial perfusion imaging was an earlier change compared to echo and ECG and clinical symptom appearances. MPI is established cardiac imaging modality as the most common use in CAD, including patients with a stable angina, because it's a functioning test. It's not only useful in diagnosis, but also for progressive stratification, and it's very, very helpful for making a clinician decision. Data textures such as TC99M can be taken up by variable myocardial cell in proportion to resultant coronary blood flow. So MPI is a perfusion and functioning test for CAD. Many different studies and the result of our institution show sensitivity of MPI around 80 to 90% and its specificity ranging from 70 to 80%. MPI using exercise tests or the visualizer like adenosis or DPW have a similar accuracies in CAD diagnosis. And now we use a greatest Spec myocardial perfusion scintigraphy. It's very, very helpful for evaluating perfusion defect. Also for ventricular wall motion and quantitatively. A range option is available for quantitatively reporting the diagnosis and prognosis based on MPI. And nowadays, using hybrid imaging, Spec CT is very meaningful for attenuation correction, adding coronary artery calcium score and the coronary angiography also. This patient with stenosis and calcification of the lesion here, but it's normal perfusion defect in MPI. There are numbers studies show MPI have a higher sensitivity and specificity in comparison with exercise ECG in diagnosis of stable CAD. And MPI have a number of advantages compared to exercise ECG, for example, for localization of coronary artery lesion, or evaluation of the CAD patient who cannot do exercise test compared to SET echo. Spec MPI is a very high sensitivity in detecting individual vessel lesion. This is algorithm is US persisting MPI is initially used in subsymptomatic patients who have likelihood of CAD around 1.5 and 1.85. Likewise, the European Society of Cardiology recently in 2019 recommended using MPI as diagnostic test anatomical and functioning for stable CAD. MPI is considered as the initial function test class 1 and evident B for symptomatic patients susceptible for CAD. Now let me to move to value of MRPI in progresses in patients with a stable CAD. 20 years ago, study done by Brown and his colleagues show patients with normal Spec perfusion have a favorable progresses. Less than 1%, it is very, very similar to the even risk in the general population. And Gibbon and his colleagues performed a study in nearly 4,500 patients, 7-year follow-up, as a result shows excellent progresses in patients who have only mild current perfusion defect. In this study, Iskander found that the patient who negative MRPI test have MRI and that's annually 0.6% compared to 7.4% if patient have a positive perfusion defect on MRPI. Hachanovic and his colleagues confirmed that cardiac event rate is very, very low in patients having mild and moderate defect. But for severe defect in MRPI, patients have a higher cardiac events. And also, this study shows CAD patients with the 3 reasons have a worse progresses compared to other have no ischemic or the only 1 or 2 segment of ischemic lesion. So, for management of stable CAD, the guideline ASCI prefers use MRPI or the coronary CTA in patients with suspected or newly diagnosed CAD. As you can see, this is class 1 or evident B or A. Now, I would like to share you the role of MRPI in CAD certification and that's what for selecting stable CAD patient for revascularization. The case study almost 25 years ago shows that there is no significant differences between CAD patient after surgery and medical therapy within 7-year follow-up. And the CABS trialist collaboration study published in Lancet also confirms that no significant differences in terms of mortality between 2 groups underwent surgery and medical therapy. And this study led by Holden shows that better outcome for surgery is a patient suffer from severe 2 or 3 vessel stenosis of CAD. Meanwhile, the patient with a single vessel lesion of CAD is favorable to medical therapy. And data from the Mayo Clinic point out that PTCA only improve significant survival when indicated in patients with acute MRI. As mainly surgery or PTCA patients have no improved survival and MRI rate. And recently, result of Courage and Barry 2D trial point out that the routine revascularization of stable CAD with PCI or the surgery did not reduce the risk of death or MRI at long-term follow-up when compared to aggressive modern optimal medical therapy. And study led by Hachanovic show the patient undergo revascularization have a increasing survival benefit over patient under medical therapy when they have a moderate to severe HKB over 10%. And recently, in 2019, this study enrolls about 48,000 patients, stable CAD patients, including 8,000 patients HKB over 5% of left ventricular in MRPI. And the results show in patients with moderate and severe HKB, revascularization was associated with significantly lower death compared to medical therapy group. And Kaplan-Meier survival analysis demonstrates that in patients with moderate and severe HKB over 10%, revascularization associated with better survival and MPI-free survival. Such a reason, so in the US, they propose the algorithm based on MPI for choosing patients with most and severe abnormality for surgery or PTCA. And we also remember that European Society of Nuclear Medicine and Cardiology in 2019 also recommended MPI indication in addition anatomical and functional test class 1 and in stable CAD patient. To summarize my talk, for stable patient, MPI have a high value not only in diagnosis but also for prognosis. And the important is that it's very, very helpful for critical decision making of stable CAD. Thank you very much for your time, and I wish all the best to you. Thank you.
Thank you, Professor Ha. We will discuss after all four speakers. The next speaker, I'd like to introduce next speaker. Next lecturer is Professor Cohen Niemann.
Hi, this is Niemann.
Okay. Professor Cohen Niemann is a very famous researcher and lecturer. He is honorary associate professor of cardiology and radiology from Erasmus Medical Center, Rotterdam, Netherlands. And he is currently associate professor of medicine and radiology of Stanford University, California since 2016. He published 4 remarkable books. Even though this is a debate session, unfortunately, Dr. Niemann cannot online today. He will give us a lecture about the Ct FFR is better. Please, video please.
Hi, this is Niemann, and it's my pleasure to root for FFR-CT in this debate on stable chest pain. So for this presentation, I do need to report collaborations with Siemens Healthineers as well as Heartflow Incorporated. Both of these companies are developing FFR-CT solutions, but I'll try to keep this as objective as possible within a debate. So I think the best thing about FFR-CT is the fact that it comes with a CT angiogram, and the two cannot be separated. The CT angiogram provides a lot of information about the presence of plaque, whether it's obstructive or non-obstructive. It provides information about coronary stenosis and can rule that out in many patients. And then there are the fact that CT angiography can be used to guide preventive measurement as well as revascularization procedures. And then finally, in those cases that we are doubting, we have functional tools to evaluate. So overall, I think the first choice test for patients with suspected coronary artery disease is a CT angiogram with FFR-CT if needed. Now, we all know that CT angiography has a great sensitivity for detection of coronary artery disease, and also the specificity is not bad at a patient level. There's a near perfect ability to rule out coronary artery disease, which has been demonstrated in many studies, in many meta-analyses, and there are now so many meta-analyses that there are meta-analyses of meta-analysis to hammer in that point. So while it's great for ruling out coronary artery disease, we sometimes overestimate the angiographic severity of disease. So sometimes, particularly when there are calcifications, the lesion turns out not to be as significant in the cath lab as we thought that it was on CT. This has also been observed in large trials, such as the PROMISE trial here, which randomized patients between CT angiography and functional testing. Now, overall, CT did really well in terms of the hard endpoints. They were very similar between CT and functional imaging. But there was an observation that more patients who underwent CT ended up in the cath lab. They often had more positive disease, and they ended up being revascularized twice as often in comparison to the functional arm. So on one hand, you can be happy with that, more disease was detected in treatment, but on the other hand, that treatment didn't visibly translate into improved outcome. So the question is whether there are ways we can avoid revascularization triggered by CT angiograms that are not as prognostically relevant. Now, our reference today for revascularization decision-making is invasive FFR and similar techniques. They were demonstrated in a number of trials, including the FAME trial, which showed that if a lesion is treated based on the FFR value, then that results in better outcome than invasive revascularizations that were based on the angiographic information. So that is a little bit our standard right now. And that's why we are trying to come up with functional interpretation of CT angiograms. Now, one of those is FFR-CT, and we'll be talking mostly about the application that was developed by HeartFlow for this purpose. And what it does is it creates a three-dimensional model of the coronary arteries and a physiological model, and combines that information to use computational fluid dynamics to calculate what the pressure and flow within the coronary arteries is and throughout the coronary arteries, and then subsequently in this color display in the middle, display the pressure in the coronary artery relative to the aorta, which is basically fractional flow reserve, displays that and can show you where there's significant drop-off and where there is potentially hemodynamically significant coronary artery disease. Now, this was evaluated in a number of trials, which showed very good correlation between the two techniques, and particularly the ability to improve specificity. Like in this example, which is actually a bit of a confusing example, but in this example where most would agree that there's a more than 50% lesion here in the right coronary artery, there is a drop in FFR to 0.83, which is still above 0.8, which would be an FFR negative lesion. So this lesion is not functionally significant. Overall accuracy improved from 65 to 86%. So a great way to avoid patients being sent to the cath lab based on a CT angiography by ruling out functionally significant disease. And the advantage of this is that it can be done without any additional testing, without any medication, and of course without a catheterization. Here's another example of a patient with a lesion in the LAD. You can see it over here, and it looks actually pretty significant, more significant even than the previous example. But still, when we did the FFRCT, we found that the lesion was not functionally significant and did not require revascularization. So what does the technique require? It requires a good good quality CT angiogram. But no other requirements are needed. And then, of course, you need to have FFRCT available, which is not the case in all countries and all institutions at the moment. Most importantly, what you don't need is an additional scan. It doesn't need to be a special scan. You don't need to give more contrast medium, and no vasodilators are required for this examination, just your standard CT angiogram. So it seems to be improving the performance of CT angiography, but how does it compare to other techniques that we use for assessment of functional coronary artery disease severity? So this is a meta-analysis that compares a number of techniques, and what you can see is like the green dots are FFRCT, and compared to several other techniques like stress echo and Spec perfusion, it does really well. And I think the only technique that seems to be outperforming it slightly is MR perfusion, but otherwise it's doing very comparatively to other techniques. There's even one head-to-head trial, the Pacific trial, in which investigators performed in the same patient CT imaging, SPECT, PET, invasive angiography, and FFR. And what they showed was that in patients who have a CT scan that is interpretable, which was not in all cases, only 83% was interpretable, but in those scans that were interpretable, FFRCT gave the best differentiation of FFR positive coronary artery disease. Overall, including CT scans that were not high quality, PET was the best imaging technique. But if your CT scan is good, there was no other technique in this study that did not include MR, but in this study there was no other technique that performed better than FFRCT. The technique has also been evaluated in large registry. This is the advanced registry that I was involved in myself, which included 5,000 patients from around the world, particularly North America, Europe, and Japan, and where the value of CT-FFR was evaluated. So most patients who have a CT scan that shows more than 50% disease, which is the type of patients that went into this registry, we feel that we need more information. In this case, 2,000 patients, more information was needed, while only in less than 1,000, there was already a clear idea whether revascularization or medical treatment would suffice. The addition of FFRCT resolved that. Very few patients required additional information. The majority will go to optimal medical therapy, and even there's some studies of some patients, for instance, 200 patients, which is like more than 20% of the patients who were originally going for revascularization were reclassified to optimal medical therapy. So in 2/3 of the patients, it provided value that changed the diagnosis and management. Those patients who have an FFR that is normal, they have very few events. Very few patients with a normal FFR will undergo revascularizations. And interestingly, even many patients with a slightly positive FFR between 70 and 80 still get optimal medical therapy, which is interesting because in the cath lab, probably these patients would have been revascularized, but by a non-invasive means, people maybe feel secure that it's only single vessel disease and no prognostically relevant disease that requires immediate revascularization. So I think that was a very interesting observation. So So the impact of FFRCT has also been evaluated in the platform study, which was a consecutive cohort study before and after FFRCT was available. And the cohort of patients that were undergoing non-invasive testing was slightly small. So the most interesting results were found in the patients that were planned for catheterization. So these patients, when no CT or FFR is available, it turns out that many have non-obstructive coronary artery disease. You can see that on the right, that the majority has that. You may say, well, that's a little bit exaggerated, but in fact, in US registries show that very similar rates of diagnostic yield of invasive angiography are observed in clinical practice. When you introduce CT angiography and then with FFRCT in case of obstructive disease, what you find is you still find that same number of patients with obstructive disease, but the number of patients with non-obstructive disease decreases substantially, and you don't have to do invasive angiography in more than half of your patients. So there's clearly an efficiency gain by introducing in this scenario. This was not significantly clear in the non-invasive test. That is something that is currently being evaluated prospectively in the PRECISE study. This is a randomized controlled trial of patients with stable chest pain to either undergo standard evaluation with functional testing or go into the PRECISE arm. Unless they are very low risk, they will get a CT scan and then, if necessary, FFRCT. Now, enrollment for this study has finished actually quite a few months ago, and we're now in the follow-up period, and hopefully in a year from now we'll have some results in terms of outcome to see whether this approach is better than the standard way we have been evaluating these patients. So when we look at the interpretation of patients who come in with stable coronary artery disease, I think CT angiography is the most efficient tool to go based on studies that have been done, but also based on the prevalence of coronary artery disease in the real world. In reality, probably not more than 10-15% of patients who come in with chest pain have coronary artery disease. And in those patients, CT angiography gives you much more information. It will tell you whether the coronaries are completely normal, whether stenosis are absent, and in case there's a lot of plaque, it may allow for more intense cardiovascular risk management with statins and other medication. And that may be one of the reasons why patients in the Scott Hart trial who underwent CT angiography actually had improved outcome, because they had the same rate of invasive angiograms, same rate of revascularizations, but still they did better, and very likely that is because of differences in management of non-obstructive coronary artery disease. Then, as you can see, these boxes that I have on this slide correlate to the proportions of what you will find in random or average chest pain cohorts. So the majority will be in the non-obstructive category, and there will be a few patients with high-risk coronary artery disease, and I think many of those can probably be sent to the cath lab depending on symptoms, but can be sent straight to the cath lab. And then there will be this category in the middle with single vessel disease of uncertain hemodynamic significance. And I think in those patients, FFRCT is a very good option to evaluate that, because the CT scan is already there. We don't have to do additional testing, and we can still get an answer if we need to know about functional significance, if that is going to affect our clinical management. I think that's always important. So with that, I would like to conclude the presentation. I look forward to hearing the positions of the other presenters, and I wish you a great rest of the meeting. Thank you for your attention.
Thank you, Dr. Professor Niemann from the US. I think this is a very, very excellent presentation. CT FFR is the better. Now, let's move to the next topic. I would like to invite Dr. Professor Ct Perfusion from Japan. He's a Professor of Department of Advanced Diagnostic Imaging via University Graduate School of Medicine. Dr. Professor Kitagawa, please.
Hello, everyone. I am Kakuya Kitagawa from Mie University, Japan. Well, this is a very interesting session where various perfusion modalities and CTFFR, which is to assess lesion-specific ischemia, are in battle. And I am to support Ct perfusion. Now let me start with a comparison between perfusion imaging modalities. Spec was introduced in 1970s and has the longest history and more evidence than stress CMR or Ct perfusion. Spec is the father and mother of the family. Stress CMR is a big brother and sister of Ct perfusion. They are already grown up and established themselves. And Ct perfusion, introduced in late 2000, they are still students. However, the youngest member of the perfusion family have shown high promise. According to a meta-analysis from 6 years ago, stress Ct perfusion, when compared against invasive FFR as reference standard, performs essentially as well as stress CMR and stress PET, and much better than stress SPECT and stress echo. And more recent meta-analysis demonstrated that Ct perfusion improves positive likelihood ratio and specificity. For example, a patient with pretest probability of 30% has 65% of post-test probability with a positive Ct perfusion. Conversely, only 4% with a negative Ct perfusion. Ct perfusion is often obtained as a part of comprehensive protocol. One of the nice things with a comprehensive protocol is to be able to look at delayed enhancement. So you can look for ischemia on a quantitative MBF map shown here, and also detect myocardial scarring with delayed enhancement. In a previous study, we have demonstrated that each of these parameters, I mean stenosis, ischemia, and scar, has unique prognostic offerings. Patients with no obstructive disease have annualized event rate of 1 to 2%. If they have obstructive CAD, annualized event rate increases to 6%. If they have either a myocardial scar or ischemia on top of obstructive CAD, then these patients have roughly 10% event rate annualized. Lastly, patient with obstructive CAD plus scar plus ischemia had the worst prognosis of all, about 13 to 16%. Now, is CT better than SPECT? As shown previously, SPECT has somewhat lower diagnostic accuracy compared to CMR or CT perfusion, and probably less suited for a gatekeeper for invasive revascularization. Furthermore, utilization of nuclear perfusion imaging is low in many Asian countries. Actually, some of the developed Asian countries in perfusion imaging is the number of perfusion imaging is quite good, but still much less compared to the United States. And in most Asian countries, the utilization is really, really low. This may be explained by high startup and recurrent cost of equipment, import and availability of radioisotopes may be probably another issue. As a result, nuclear perfusion imaging is available only in major urban cities and may not be covered by health insurance. Then, of course, there's insufficient training and staffing. Well, okay, how does Ct perfusion compare with stress CMR? Actually, they are brothers and sisters. They both use first pass circulation of the extracellular contrast medium. Naturally, there is a very good correlation between CMR and Ct perfusion. In this example, perfusion defect in LAD territory shown here on CMR is nicely appreciated on the MVF map of CT shown here. In a recent head-to-head comparison of Ct perfusion and CMR, the performance of Ct perfusion was comparable to CMR perfusion. Now let's talk about the difference between Ct perfusion and CMR. Firstly, quantitative analysis is a clinical routine if you implement dynamic stress Ct perfusion. It takes only 5 minutes to obtain voxel-based MVF map. Routine quantification of perfusion is feasible with MRI if you have dual T1 sensitivity sequence. But this sequence is not widely available yet. Second advantage of Ct perfusion is spatial coverage and resolution. Stress CMR typically acquires 3 short axis slices. That is, if presented in a polar map, it's gonna be like this. So, significant proportion of LV myocardium are not imaged at all. With Ct perfusion, entire LV myocardium can be captured. Of course, there is a whole heart dynamic MR perfusion sequence. But again, this sequence is not widely used. In addition, you have to choose between whole heart coverage and quantification. So this 3 whole heart MR perfusion and dual T1 sensitivity perfusion is not compatible at this point. With CT, quantification and whole heart coverage is compatible, and in addition, you can choose any slice in any thickness for both perfusion and delayed enhancement. This is another important advantage of CT. Let me show you a clinical example. This 66-year-old female had previous stent placement in right coronary artery and circumflex artery. Distal stent in circumflex and right coronary artery are actually difficult to assess. At least in the LAD and first diagonal branch, there is no significant stenosis. However, this patient has a fourth angina. We performed a perfusion and delayed enhancement and found that there is a small infarct in the inferior wall, shown here. However, there is no ischemic defect because the size of the perfusion defect is almost the same as the infarct size. On the other hand, in the anterior wall, there's a perfusion defect without delayed enhancement. So this is ischemia. However, there is no stenosis in LAD or first diagonal branch. So how can we interpret this discrepancy? Well, in this case, fusion of coronary CTA and Ct perfusion was useful. The anterior perfusion defect locates just between LAD and first diagonal branch. So we reviewed the previous X-ray angiography and found a diffusely diseased second diagonal branch, which demonstrated reduced and slow flow. So in this patient, there is ischemia in the anterior wall, but there's no indication for revascularization. We decided to follow up this patient medically. Well, Ct perfusion is still young and the clinical evidence may be less than other modalities. However, Ct perfusion is highly competent with the ability to be integrated with CTA and CT enhancement, routine MBF quantification, complete coverage of LV myocardium with highest spatial resolution. Ct perfusion is probably inexpensive compared to Spec and potentially more widely available. Now moving on to the comparison with CT-FFR. Well, CT-FFR, I think this is like a robot. Why robot? Because there's no need of training and staffing for CT-FFR if off-site CT-FFR was used. It works under certain conditions, and good image quality of CTA is required. There should be no stent. It works as programmed. And this is an important point. The results are simulated data. Actually, I have a concern on this point In Ct Perfusion, we obtain real data, not simulated, and based on it, we infer an explanation, right? On the other hand, in CT-FFR, the process is deductive. So theory comes first, and will make a prediction. However, as the assumptions are being compromised in individual situations, CT-FFR represents the probability of a positive FFR. The image, it looks like FFR, but the value should be interpreted in the context of probability of a positive FFR. The results of Ct perfusion is not probabilities. They are real data, what really happened, okay? Therefore, we can use it to study pathophysiology of coronary artery disease. Although CT-FFR is generally believed to be clinically useful, according to a systematic review, accuracy of CT-FFR is high at extremes of disease severity. For more intermediate disease, CT-FFR is unreliable, especially in the range between 0.65 to 0.8. This CT-FFR image was obtained in an asymptomatic man who underwent PCI 1 year ago. There is untreated LAD disease with borderline invasive FFR of 0.75. Although CT-FFR suggested a high likelihood of significant disease for LAD artery, Ct perfusion was normal. Now, which modality do you believe, CT-FFR or Ct perfusion, simulated data or real data? We decided to follow up this patient medically, and after several years, he is still uneventful. Lastly, you can evaluate the effectiveness of PCI with Ct perfusion. In this example, ischemia in the LAD territory, shown here, was successfully normalized by stent placement in the LAD. The perfusion is completely normalized, right? You may notice that there's another stent in the circumflex here. However, the effect of stent placement for this vessel was minimum because there's only a slight subendocardial perfusion abnormality here. Of course, we have to be careful about radiation, use of iodinated contrast media, use of vasodilator stress, and prolonged examination time. Nonetheless, Ct perfusion is better in so many ways. Advantages of Ct perfusion include complete LV coverage, high spatial resolution, routine MBF quantification with more objective assessment and evaluation of effectiveness of treatment, fusion with coronary CTA, integration with delayed enhancement, and Ct perfusion is inexpensive and it does not depend on quality of coronary CTA. Lastly, Ct Perfusion produces real data, which will probably contribute for advancement of our understanding of the pathophysiology of coronary artery disease. Thank you very much for your kind attention.
Thank you, Professor Katawa from Japan. I think this is a very helpful presentation and excellent presentation. It is confirmed that Ct perfusion is one of the most useful method for stable CAD. Now let's move to the last topic. So I would like to introduce Dr. Professor James Moon from UK. Professor James Moon is a professor of cardiology and in the clinical lab CMR by Heart Center. He have a number of publications and the book, very famous professor. Dr. Professor James Moon, please.
Highlighting that perfusion CMR is the better test. I have no conflicts of interest, but I do have to apologize. I was expecting to give this talk live, but unfortunately I need to be on a plane at the time of the talk, so I'm unable to do that. So we have lots of imaging modalities available, and as clinicians in a care pathway with responsibility to patients and payers, we need to find the right tool for the determining who has obstructive coronary artery disease is something we do to target therapy, and we can do better than invasive coronary angiography when the pretest probability is not very high. And we have lots of choices for doing that. You've heard about tests that are anatomical and tests that are functional. And they all, the functional tests rely on the ischemic cascade. I'm going to be highlighting using MRI scanner as a camera to measure myocardial perfusion during adenosine stress. So as you can see, myocardial perfusion abnormalities occur earlier during ischemia. This is non-invasive with no ionizing radiation, and we are measuring blood flow, not contractility. CMR is a platform technology, and our patients can benefit from performing multiple different assays, if you like, at one time. We always look at the anatomy and the structure and function, which has significant advantages because we can look at the entire heart, including the apex and the base, which can sometimes be poorly seen by, for example, echo. But those advantages are useful, but really come into their own when you add the scar imaging, which is of high prognostic significance. Here you can see a partial thickness circumflex territory scar, for example. We are now overlaying that with the perfusion, which I'm going to talk about more, and more modern techniques to interrogate the heart muscle for processes that occur before scar, such as myocarditis, infiltration, storage, etc. This is the typical product of conventional adenosine stress perfusion CMR. What you can see is the scan is repeated twice, once at rest, once at stress. At rest, the contrast agent blushes into the RV, then the LV, and then blushes into the myocardium. And at stress, when there's vasodilatation, the consequence of an epicardial flow-limiting stenosis is to cause a perfusion defect, a quite marked one in the lateral wall, 5, possibly 6 segments here. And that test is now very established. Here are some 6-year-old guidelines showing class 1 indication for intermediate probability coronary disease. That recommendation has been made on the basis of evidence acquired over the years. First observations were in 1990 with initial single center work here in Circulation by Jörg Schwitter, and then Eike Nagel again with more validation, becoming multi-center, initially single vendor, then multi-center, multi-vendor information, and finally amounting in trials where the endpoint was not outcome, but comparison also for care pathways in the CMARC 1 and 2 studies. This trial data has been complemented by more recent approaches here in the USA with the SPINS registry, which is much more real world and showing results from 13 centers in 11 states, 2,300 patients in stable scenario. And what these show is that the CMR results for ischemia are prognostic, but also that you need to think in a more joined up way and look at other parameters. And here it shows that the combination of scar detection by CMR, which is the true standard for scar imaging, and ischemia is highly prognostic, both for the primary and secondary outputs. Take-up of that is quite high in some domains around the world. In my country, there's near full adoption. At my center, we do around 6,000 perfusion CMR scans a year. We're the largest center. The UK does 114,000 scans a year, and around a quarter of those are for ischemia. There's some regionality, as you can see, with some more uptake in London. And you can also see that there are a large number of radiologists and cardiologists reporting CMR and doing this as part of their routine job for patient care every day. There are advantages of this over nuclear imaging, including rubidium SPECT, and that is about spatial resolution, which is good in plain, although typically we use 3 slices rather than full heart coverage. The resolution does mean that we pick up other pathologies. Perfusion can fall for other reasons, not just epicardial flow limiting stenosis, but also if the microvascular is blocked here acutely in microvascular obstruction, or if there is microvascular disease or in some forms of scar. And that is both a disadvantage if you are looking purely at the results and trying to interpret epicardial coronary disease, and an advantage because it's new biology that you may be able to look at. We have improved gradually the process of perfusion CMR over time. We certainly did have a problem with some understress in the early days, and we've learned from the radiologists in particular to look below the diaphragm, because with adenosine, during vasodilator stress with adenosine, the spleen vasoconstricts. Peristalsis also turns off, and that's allowed us to detect people who are otherwise understressed. What I've been showing you so far is semi-quantitative. We are now well on the way towards quantitative perfusion, which has got increased accuracy and precision and has the potential to be faster, detecting better balanced ischemia, which has always been a problem. It also carries new prognostic information. I want to show you some of these ones. The workflow is adopted on the scanner, so there's no post-processing needed. The scanner does all the work for you. Here with Perfusion Mapping, which has been developed by Peter Kalman on one of the platforms, Siemens, but Siemens is a very dominant camera, if you like, for cardiac MRI globally. And what you get is maps, no moving pictures now, but maps where each pixel is the blood flow in mils per gram per minute. So if you look at the bottom of the normal, the blue circles, base, mid, apex, have a blood flow of around 1 mil per gram per minute, but the top images have around 3 mils per gram per minute. And you can see on the right hand side that there is multivessel disease with probably two vessel disease here in the stress where the circumflex and right coronary have not vasodilated. Perfusion mapping has been exploiting better sequence design with motion correction, full quantification, and automatic AI analysis, so you get a readout of segmental values without having to do any manual work. These segments have been drawn by computer. There are lots of quality assurance outputs as well, which allow greater confidence that can cascade to patient care. You can see here an example again, stress rest with two vessel disease, mid, anterior wall, and then circumflex. These are quite simple to read. This has gone through the appropriate milestones needed for a new test, with a lot of data coming through and around 15,000 scans done with full quantification so far at around 15-20 sites. This is some of the latest data from my group, where we've looked at 1,000 patients and looked at follow-up for MACE across 2 centres, and we've shown that the stress myocardial blood flow and the myocardial perfusion reserve are both prognostic in a real-world scenario, an important milestone for the technique. As I mentioned, however, blood flow is not just dependent on the epicardial coronaries, and I think there is something to be learnt here for the CT-FFR groups, for example. If we look at the amount of vasodilatation one can get in patients who do not have epicardial obstructive coronary artery disease, then the average is 2.66 mils per gram per minute for a 60-year-old with no LVH, non-diabetic, no beta blockers, but falls as you get older, rises as you get younger, falls with LVH and with diabetes. So what normal is depends on your demographics and intercurrent comorbidities, which is important when you're doing modelling. If we look at other conditions outside epicardial coronary disease, we find quite marked perfusion defects in cardiomyopathy, especially heart muscle disease with hypertrophy. Here I'm showing apical predominant hypertrophic cardiomyopathy, where there are dense apical perfusion defects, and in the basal septum here. Quite a characteristic finding. We find that in perhaps 60 to 70% of all our HOCMs. More interestingly, perhaps, is that we are seeing these perfusion defects before the onset of LVH. This paper was published earlier in the year from my group, and it shows here in a patient, 2 patients actually, with no LVH, that there are quite marked perfusion defects in the septum, the area where LVH is expected to occur as the disease phenotype expresses, and that those perfusion defects are not caused by epicardial coronary disease, and that they are preceding overt hypertrophy, and in almost all cases preceding late GAD. There's a tiny bit of late GAD in one of these, but you can also see that the hypertrophy is the ischemia is much more extensive. We are on the cut frontier here. CMR is an excellent platform for exploiting artificial intelligence, and we're now using this in our routine clinical care here for feature extraction, the LV cavity, for the AI analysis, and for segmentation, making the clinician's job easier and faster and allowing them to do more with the same information. So to summarize, CMR perfusion quantification. There are lots of advantages of functional imaging. The camera, that is an MRI scanner, has high resolution and does not use ionizing radiation. But its real advantages are that you combine the ischemia detection with structure, function, and scar imaging to give you the richest insight into your patient's condition. Perfusion CMR has a robust evidence base, and in some countries, like my country, have high adoption rates. I've also shown you that this is not a static technique and that research is ongoing, and full quantification is going to add value and I think open up new understandings about heart muscle, particularly in cardiomyopathy, meaning that the future is bright for this technique. Thank you very much. If you want to know more about Perfusion CMR, you come to the SCMR conference in February in the USA. It will be a in-person and virtual meeting, we hope. And I mentioned this advert because I've been talking on behalf of SCMR in joint working between ASCI and SCMR. Thank you very much.
Thank you very much, Professor Moon, for your comprehensive lecture. Now, this debate session is open to discussion for audience. But unfortunately, as I mentioned, Professor Niemann cannot online today, and Professor Moon is on a flight at this moment. So only two lecturers, Professor Kitagawa and Professor Ha, is now online at the moment. Is there any comment or a question from the audience to lecturer, Professor Kitagawa and Professor Ha? There is no comment or question. So,
in my understanding, I think it's a Ct which FFR is a very useful for detection of CAD, stable disease. But in some country like Vietnam, we are the developing country. So right now, using the technique like MRPI is very classic and useful for diagnosis and prognosis and making clinical decision. Because you know that the Ct perfusion or MR perfusion is not common used in Vietnam right now. So I would like to ask you in Korean, how about the situation and Japan also, please?
Okay, can you hear me?
Yes.
Right?
Yeah.
Okay. So for perfusion imaging, actually, Spec dominating the current market of the current perfusion market. And the number is almost stable for like 10 or more years. And number of CT has skyrocketed to like 500,000 per year, which is more than the invasive coronary angio. And the number is, of course, more than the perfusion Spec. And so, in my opinion, if only like 10% of the CTA is associated with CT perfusion, the number is quite good. And it's actually much more than the MR perfusion in Japan, which is less than 40,000 so far.
Okay. In Korea, the number of examination is somewhat closely related with the reimbursement, as in other countries. The Spec is previously reimbursed by the government, and recently cardiac MR is reimbursed. So nowadays, MR perfusion is increasingly in the clinical situation. And also, coronary CT angiography is reimbursed, has been reimbursed, but the Ct perfusion is not separately reimbursed. So clinicians usually perform a CT angiography first, and then they do usually MR perfusion or Spec in Korea. But in some institute, it depends on the institute situation. They do actively perform Ct perfusion in the study purpose. Okay.
Okay, thank you. So in Vietnam right now, as insurance is not paid for perfusion, MR or the Ct perfusion. So we do the exercise test, echo, or MRPI only.
Okay.
Just do for research, some research. Yeah.
Okay. There is one question on chat box. The question is how to distinguish dark rim artifact from sub